It is just a huge honor for me today to be podcast interviewing Dr. Mario Romero, DDS. He's an associate professor and director of the Advanced Education and General Dentistry Program at the Dental College of Georgia at Augusta University. He is a 1995 graduate from the University of Guayaquil School of Dentistry in his native country of Ecuador. Did I get it? Guayaquil?
Guayaquil, yes.
Okay. He completed a 2-year advanced education and general dentistry program at the University of Rochester, Eastman Institute for Oral Health, where he was granted the Handleman Award for Excellence. In 2016, Dr. Romero was awarded the Augusta University and the American College of Dentists Outstanding Faculty Award for his achievements in scholarly research and service. In 2018, he received the Research and Scholarship Award from the Dental College of Georgia for his contributions to dentistry, and in 2019, he received the Excellence in Dental Education Award from the Pierre Fauchard Academy. Amazing. He has over 40 publications in national and international peer-reviewed journals and has lectured extensively on topics related to direct and indirect restorative dentistry. He maintains a private practice with emphasis in aesthetics and restorative dentistry for 15 years prior to joining AU in 2013. It is just a huge, huge honor for me to have you come on the show today. Thank you so much for taking the time out of your busy day to come on the show.
No, thank you very much for inviting me. I mean, like I was telling you at the beginning, I'm a fan. I listen to your show. I think it's a great show because there's so many things that you talk about in your show that are really not taught in dental school, and like you call kindergarten dental school, and you know, it's just something that you learn with time. I mean, you just gotta, the years have to go by, experience, and sometimes you can make that shorter when you have shows like this that we are able to have today thanks to technology. And you know, we can talk about anything we want, and people, believe it or not, they learn. I mean, I've learned a whole bunch of stuff listening to so many people that you interview following your show.
Well, you know, you're on cutting edge. I mean, you're talking about minimally invasive procedures, bleaching and bonding prototypes, micro-abrasion veneers. I love your YouTube channel. If you haven't been to his YouTube channel, it's Romero Dental Seminars. You have several thousand subscribers. I was watching some of your videos on my iPhone, and I said, I want to get this guy to come on the show. So, if you're an old guy like me, when I got out of school in 87, the fillings were all amalgam. Hell, they lasted forever. The crowns were all gold. They lasted forever. And in my generation, it kind of seems like 2 steps forward, 1 step back, where you replace this long-lasting amalgam with a shorter-acting composite. How does a gold crown break? And now we replaced it with, you know, porcelain fused to metal. I can't believe I'm so old that I saw the invention of porcelain fused to metal and then its extinction. So I've lived through the birth and death of an entire species. I don't even know if they do PFMs anymore. Do you think it was an aesthetic health compromise? Do you think we should go back to amalgam and gold? Or do you like this tooth-colored resin?
Well, you know, I think that let's look at this in 2 ways. Let's look at it first on the passion, dentistry passion way, the way that you speak and the way that you talk about different materials and products. You know, personally, I think, and I agree with you, you know, I've seen patients that come to see me and have an amalgam or a gold onlay, and they've been there for 50 years, and you look at the margins, everything is beautifully sealed, there's no staining, and they were cemented with zinc oxide cement. I mean, they were probably used very old type of cements that we don't even have today, or we don't have any access to them today anymore, and they're still there. And then, you know, you go into newer materials today where they're all ceramic, all white, because that's probably what the market is pushing towards. And that's not the dentist making the decision, but the market making the decision. People wanting white restorations or white fillings. And then suddenly you start seeing some staining and some recurrent decay around the margins. Now, the thing that I always try to express and teach when I'm teaching dentistry is that the reason why gold has been, or amalgam has been so successful throughout the years, longevity-wise, is because they were less technique sensitive. So, you know, you didn't have to worry about isolation when you were building up amalgams. You didn't have to worry about any adhesives or bonding. If it was a 5th generation or a 6th generation or 7th generation, did you need to edge or no edge? There's so many decisions that we have to make today when we're actually performing clinical dentistry that if you don't understand the process and you miss one of the steps, obviously that's going to affect the outcome of your product. And that, for me, is what really happens with white materials today. When you see them fail, they fail more because of lack of a good technique than because of the product being a bad product. And I'm going to give you a good example. Just a year ago, actually, because I saw this patient just 2 days ago, and this was a 1-year follow-up. A patient came to me. I know the dentist. He's a friend of mine that he did 35 years ago. She had stained teeth with tetracycline stained teeth. 35 years ago, he bonded composite to all, canine to canine, all the way back to the second premolars. 35 years ago. Now, you know what we were using 35 years ago. I mean, they're nothing to do with what we have today. And 35 years later, I removed them and I placed porcelain veneers because the patient just did not want to see, composite is not as opaque as porcelain. So you're going to see some of that grayish underneath the composite. You're going to see through the composite. And I have the photo 35 years later, a little bit of staining here, a little bit of opaque resin here and there, but they were bonded. They were still in the patient's mouth. So this, for me, is proof, more than proof, then when these products are handled the same, with the correct protocol, they will last. If they are failing in your hands, many times it has a lot to do with your protocol more than with the actual material. We cannot fight what's going on today in the market. You rarely have patients that come to your practice and tell you, please remove this old amalgam and replace it with a new amalgam. That doesn't happen. So because that doesn't happen every day or it doesn't happen so often, we got to make sure that if we're going to change an amalgam using a composite, we do the best we can to get that composite to last as long as possible if we follow a good protocol.
So most of the feedback I get, Howard at dentaltown.com, or the comments in the YouTube, the comments after the YouTube video, they always like to know specifics. So they're young kids, they just got out of school, and the first thing they're thinking is, what dental adhesive do you use? Because it started off with conditioner, primer, adhesive, then they've rolled it all into one. And now, granted, I hang out with a bunch of old 50, 60-year-olds, but we're kind of sitting there thinking, really, was it that hard to put on blue and then rinse and put on primer? And it had to be just one drop, because I don't want to be getting a heart bypass and the doctor says, well, I don't want to make 2 steps to save Howie's heart. I just want 1 step. So is the 1 step, is that just too fast? I mean, should it be, what bonding agent do you use?
Well, and that's a really good question, because again, we talk about all the time, and even in private practice. I mean, when I was in private practice, and I did it for 15 years, so I know exactly what it is and the way it should be ran. Is, we all talk and we're all saying and defending, we're doing this because of evidence, and this is the evidence here. Everybody's talking about evidence, but do we really use evidence? Now, if you think about that simple word, evidence, what is the material or the type of adhesive that has the most evidence that we know that works very well, and that we know that is the least technique sensitive compared to any other adhesive out there? And it's going to be the 4th generation, just like you said it, acid edge, prime and bond in 2 separate bottles. And I tell a lot of my residents and many dentists that when we're doing CE courses, I tell them, how much time do you really save? How much time does it take you to add a separate drop? 5, 10 more seconds? Is 10 seconds really going to make a huge deal at the end of the day? Money-wise or time-wise? No. The answer to that question is no. So if I were to use, and today I think that you have to really think about the adhesive based out of what you do in your practice. Let's say that you're a recent graduate. What are the recent graduates doing the most when they become associates in a dental practice today? Bread and butter dentistry. Operative dentistry, 80% of the day. So if I'm going to be bonding direct restorative composite to molars or anterior teeth, you would only need to have a 4th generation dental adhesive in your practice, and you don't have any problems. Now, if you have a practice that has a lot of indirect restorations and less direct restorations, so then maybe I will go to a single bottle adhesive, because many of those direct restorations, like for example, porcelain veneers, you're going to bond to strictly, or the majority of the tissue that you're going to bond to is going to be enamel. So on enamel, you don't have the difficulty of the bonding step as you do have in dentin. So we all know that dentin is a difficult substrate to treat compared to enamel. So you got to look at it in many ways. Now, if you ask me, I have a practice and I run a clinic with residents, but I see my own patients as well. And I do a little bit of both. So I have a 4th generation dental adhesive and I have a universal dental adhesive. And I use both on difficult clinical situations.
And they'll want to know your brand, though. What brand of universal? What brand of 4th generation?
I use for 4th generation. I use OptiBond FL from Kerr, and for 5th generation, for universal adhesive, I use 1-Coat 7 from Colteen, and I use OptiBond Universal from Kerr.
OptiBond Universal from Kerr.
Yes, and 1-Coat 7 from Colteen.
1-Coat 7?
Yes, sir.
Huh, I must have missed that. 1-Coat 7 from Kerr. Or
from Colteen.
From Colteen. Coltene?
Yes, sir.
Huh, okay. And interesting. That is very interesting. So back to minimally invasive. When I've had the honor to meet some 90-year-old dentists still practicing. One was in St. Joe, Missouri, George Rui. The first, his son, George Rui. Second was a dentist. His son, George Rui. The third was a dentist. But whenever I'm with a 90-year-old dentist and I say, what tooth lasts the longest? They, thinking, is it a molar or canine, incisor? They always say, it's the tooth the dentist never touched. Every time you touch a tooth, you condemn it to retreatment. And I love the fact that everybody's trying to get minimally invasive. What does minimally invasive mean to you?
Well, that's a great question because I talk a lot about this because my understanding, if you think about the word minimal invasiveness, means that you're going to do the minimal possible to that tooth in order for it to look better, to be restored. And obviously, minimally invasive dentistry today has a lot to do with aesthetic dentistry. They both kind of like have merged together. Because if you have a patient that has decay everywhere, there's no minimally invasive dentistry that is possible for this patient. You can only do minimal intervention on patients that have fairly healthy teeth. That's why you're minimally going to intervene. Now, the thing is that when you merge these two different sciences, aesthetic dentistry and minimally invasive, I believe that we make one big mistake. You can see many cases and many lectures today and in many publications where you see people that end up having 12 veneers and somebody calling that's a minimally invasive procedure. For me, minimally invasive procedure is I don't want to touch any tooth. I want to do anything that does not require removal of tooth structure. So I have a lot of these cases. And again, I start asking and I always start thinking about aesthetic dentistry, that beauty is in the eye of the beholder. Beauty doesn't mean to me every tooth has to be B1 or B0.5. Beauty doesn't mean to me every tooth has to be perfectly straight or every tooth has to be perfectly symmetric. Beauty is based out of what my patient likes or dislikes. That's the first thing that I do. And that mentality will keep you in track with that minimally invasiveness. Because I've had a whole bunch of patients come to me and say, you know what, there's something about my smile that I don't like. And I look at their teeth and, they're healthy. They've never had any feelings. You can tell that these have been patients that have been taken care of very well. But they just have something in their smile that they don't like. And they just don't know what it is. If they fall in the wrong hands, you can end up with 12 veneers. Or you can fall in the right hands, have your teeth bleached, go from A3.5 to A1 or B1, and probably that was just what the patient wanted. Once he looks at his teeth and he notices that his teeth have brightened and that the smile is brighter, maybe that's all they wanted. And I have found that to be true 9 out of 10 times. Patients that are healthy, that they come to me and tell me, I want to have my smile improve, and there's something I don't like about my smile, but they cannot tell me exactly what is it that they dislike. And those patients for me are the number one candidates for minimally invasive dentistry. Now, minimally invasive dentistry, I see it with three different steps. And only when I have completely used those, I've gone through first, second, and third stages of minimally invasive, that I can go to the next step, which to be now slightly invasive, meaning there's some modification of the tooth structure that I'm going to need to do for this patient before I go ahead and improve his smile. And those are bleaching, number one. Number two, micro-abrasion of the enamel that will be able to remove a lot of white spots, brown spots, a lot of extrinsic staining on the surface of the enamel. And then finally, you can always do resin infiltration if you have some of the white spots left behind. I mean, again, if you have different colors and textures of the teeth, there's so many things that you can do before you put a burr onto that tooth. And that, for me, is what I consider minimally invasive. Minimal intervention or no intervention. I can do anything of these three steps that require no burrs, no numbing of the patient before I get to any procedure that requires for me to be more aggressive to the tooth structure. And again, if you ask any dentist, and I have a lot of dentists that are my patients, when they come to my practice and they see me here at the school, I ask them, I want to improve my smile. And all of them would like to go through procedures of minimally invasiveness. And I even have a lot of cases where I have a lot of chipping of the incisal edges because of trauma, minor traumas. I restore those with composite with no preparation. I do not reduce enamel if I don't have to. I will double my etching time, and I will restore that with composite without applying any burr to the tooth. And that makes my treatment always reversible. If it fractures in the future, if it stains, if anything happens, I can remove it with a disc, with a finishing disc, and all I have underneath it is 100% the patient's enamel. So there's a lot of things that you can do without touching the tooth with a burr. Well, even porcelain veneers in some cases.
Well, you talk about minimally invasive. I also love your YouTube video and some of the articles you've written on BFEP, Bonded Functional Aesthetic Prototype, where you do a long-term provisional technique called the Bonded Functional Aesthetic Prototype, BFEP, allows dentists and patients to work together to enhance the outcome of therapy when increasing occlusal vertical dimension. So you're going to increase vertical, you can work it out in temporaries. Talk about BEEP. So you should have named it something that's BEEP. BEEP would have been better, but you had the F in there. Well, how do you say BFEP? Is that BFEP? BFEP?
Well, the Bonded Functional Aesthetic Prototype is not a name that I brought into the literature. This name was actually brought in by Dr. McLaren. But this is something that has been in dentistry for years. I mean, I would say that Body Mopper probably was the first one ever to start placing composite on teeth and using them as a temporary or intermediate restorative material before getting porcelain veneers into his patients. So that's where this trend comes, and then finally gets to the hands of Dr. McLaren, and he brings out this term, Bonded Functional Aesthetic Prototype, into the literature. Now, what I've done with this prototype, because they use it a lot for veneers, what I have done is I actually have incorporated the same concepts, but now I use them even to increase vertical dimension. In other words, I use them to build full crowns onto my patient's teeth using flowable composites, and using the same concepts behind the Bonded Functional Aesthetic Prototype technique. And, this has become such a useful thing for me. And I use it, almost on a weekly basis on my big cases, because what it has done for me is that it allows me to put something, an intermediate type of prosthesis in my patient's mouth without having the patient have any huge compromise. And if we think about this together, you do dentistry, and all your listeners do dentistry, they will understand this very well. You get a lot of patients today with a lot of erosion, and young patients, there's soft drinks, water, all that has a whole bunch of acid. You get a lot of erosion, and you get a lot of wear after the erosion, because the erosion will break down the enamel, the dentin will be exposed. If the acid is still involved, you will now get more enamel eroded and the dentin, because dentin is less mineralized, so it will just wash away easier. So let's picture in our minds a patient with a lot of wear all around his mouth, upper and lower arch. Now you know that you're going to have to modify, you have to increase the vertical dimension, because this patient, most likely, because of the aggressiveness and how fast the tooth was eroded, this patient has lost vertical dimension. So if you were to increase this patient's vertical dimension, there's only two ways that you can do this, or three. One way, you can fabricate a splint, give it to the patient, send the patient home, and test drive your new vertical dimension to see if there's any pain or tenderness or any discomfort in the TMJs with this new vertical dimension. Or you can go ahead and prep all the teeth, prep them for crowns, put temporaries at a new vertical dimension, and then send the patient for your test drive. with the downside that number one, the patient is already invested in the treatment because he's going to have to pay not only biologically by you removing the enamel and some dentin, but money-wise, financially, because you're going to have to build, there's a lot of hours involved in your chair time to get that patient to that point. Or third, my proposal, you don't prep any tooth structure, you don't remove any tooth structure, you bond these prototypes based out of a wax with an increased vertical dimension directly onto the patient's teeth and send the patient home. Now, not only there is no preparation of the tooth, so there's not going to be any hypersensitivity, there's not going to be any issues because the tooth structure of what the patient presented with is right underneath your prototype. Not only you're going to be able to use them for that, but then once you're ready for the treatment, once 1 week or 4 weeks or 6 weeks, whichever time you decided to leave the patient with the prototypes to get your diagnostic information, now you can prep through the prototypes, meaning that you're going to use those prototypes as your preparation guides or calibration guides, which integrates the whole treatment into that and makes it a lot easier through the whole process. And, just to let you know, we are actually, this has become such a big thing in what I do and what I teach today, that September 28th in Atlanta, Georgia, we're going to have a course, hands-on course, only on this topic. And we're going to teach people not only how to do the bonded prototypes, but how to use them as preparation guides, how to calibrate the preparations using these prototypes so that they can make it a lot easier in their practice when they have these big cases. And this, I think, is something really good for the younger dentists, because every dentist, and when I say younger, I'm saying kind of like between the first and the 10th year out of dental school. They're getting comfortable now at prepping single crowns, 3-unit bridges, but some of them still feel uncomfortable doing full mouth reconstructions, full mouth rehabilitation, because as me and that's a more complex thing. You got to maintain the vertical dimension that you increase, and you got to maintain that throughout the whole process of all the impression and sending all the casts to the lab. Well, guess what? If I am able to do the prototypes, now I can segment or divide my rehabilitation in different areas so that I can do 4 crowns at a time, so that I can do 6 crowns at a time without losing the information on my vertical dimension and keeping the prototypes in place. So there's a whole concept, a whole big concept, as you have been able to see and read in my articles, where this is super useful. And not only for big cases, but also for partial cases. I'm going to give you another example. Let's say that you have a patient that needs porcelain veneers, and because he's got wear on the incisal edges, wear on the facial aspect of the teeth, and you think that porcelain veneers are the indicated type of restoration for this particular patient. So what do I do for these patients? Before I go ahead and prep those teeth, I'm going to wax the case up, and I'm going to fabricate a prototype and bond the prototype directly to the patient's teeth. Now I have a new location of the incisal edge. I have a new emergence profile, and I have a new buccal surface or buccal volume of all these new teeth that I'm going to restore. I can send the patient home, have her or him wear it, function with it, have other people around them see my prototype. Do they like it? Do they dislike it? Do they feel that the teeth are too big, they're too small? I can add, remove, I can do anything to my prototypes. Once the patient is convinced that this is what they want, I make an impression on my prototypes and I prep through the prototypes. That impression, I send it to the lab. The lab will scan my prototype and they will reproduce the length and the contours of my veneers onto their final restorations. So the delivery day, I don't have to spend any time thinking about, do I have to adjust the incisal edge? Am I going to have to adjust a contact here or emergence profile over here? Everything was set from the get-go with my prototypes. So it simplifies your actual workload. It simplifies the way that you manage your cases in the practice.
I would give anything if you taped that hands-on lecture and made an online CE course on Dental Town. We've made 400. They're all about an hour long, hour and a half. They've been viewed almost 1 million times because a lot of dentists, before they close down their office and fly across the country to go to the course, they kind of like to see an hour teaser.
Right.
Like I think the Painting Institute in Dawson was very smart. They have week-long courses. So they did a 1 hour summary of each one of their courses. It's kind of an intermediate between I read, I saw your name versus I spent the day, but man, I would just love it if you.
No, and I have what I can do for you is what I'm actually going to do for you. This is my word on this. I'm actually going to fabricate an online course where I'm videotaping myself doing every single step of the hands-on that we're going to do in Atlanta, Georgia, September 28th, so that your homies, is the way that you call them, I think, if I'm not mistaken, your homies can actually watch. Now you know that I was listening to your podcast. Your homies are going to be able to watch me. I'm going to walk them through the process so that they can actually watch me do it on the cast. I'm going to do live on a video for you so that they know what the steps are. And again, once you watch the video, you take the hands-on course, or you do this with us, it's really easy to transition from that to your practice, because normally every single dentist is using flowable composites and know exactly how to use them in their practice. We're just taking the flowable composite to the next level.
Well, one thing that I called baloney on when I got out of school in 87, all the cosmetic gurus, I noticed they were always filing down everybody's teeth for veneers. But when their exact daughter needed it, it was bleaching and orthodontics. And I started to not trust any cosmetic dentist who couldn't unravel the teeth with ortho. And even with veneers, like if it was my, I didn't have any daughters. I just had 4 boys. But my one granddaughter, if she needed veneers, I would do direct veneers. Talk about minimally invasive. I mean, the direct veneer cases that I've seen look the most natural, and they don't hurt the teeth. And so I really love the direction it's going towards minimally invasive. I like direct composite veneers better than filing down enamel and doing indirect veneers. It's just, but you said the most minimally invasive was the easiest thing to do is bleaching. Are there any tips? Is bleaching? I liked your YouTube video on bleaching tray fabrication. What tips would you give on something like bleaching? Does the tray even matter? Does the brand of the bleach even matter? What matters in bleaching?
I think that what really matters, and I don't know if you know this, but here at the dental school, Dr. Van Haywood is one of the faculty here, and Dr. Van Haywood is the first ever dentist that have a publication on night guard bleaching. So if you want to talk about a guru in bleaching, we have him here at the school. So when I was in private practice, and I know what many of your homies are probably thinking, and the same way that I thought when I was in private practice, the stronger the product, the faster and the better. And if it's kept in my office, patients are going to feel that they're going to, I'm doing something for them. It's like if I send them home with a tray, they feel that I'm not doing anything for them. That was part of my bleaching protocols when I started dentistry. But with time and learning and reading and just seeing my cases, I found out that with 10% carbon peroxide, you can do everything. And it's the cheapest, the most efficient, and safest product out there. So I would say that for the last 7 or 8 years of me being a dentist, all I use is 10% carbon peroxide. And I have yet to find a case. And I'm telling you, we do bleaching for single dark teeth. We do bleaching for, we do internal bleaching using, and I rarely do internal bleaching, but if I have a case where I need to do internal bleaching, I would do I would use 10% carbon peroxide. So I use it for everything. And the good thing about the video that you just watched, if you watch the video closely, you will see that I don't use any blockout resin. I mean, there's no spacer on my cast. We fabricate the tray directly onto the cast with no type of spacer placed on the teeth that we're going to bleach. And the reason for that is because you really don't need a lot of the product. You just need some contact of the product with the tooth. So if you don't use any reservoirs, that means that the patient is going to be using less of the product. And the patient is going to, the majority of my cases, 9 out of 10 cases that are just regular normal cases, vital teeth, my patients, I give them one kit, and I use opalescence at 10% made by the Ultradent. I give them one kit that brings 8 syringes, and 9 out of 10 of my patients end up doing their entire mouth with 5 to 6 syringes. meaning that they have at least 2 to 3 of them left over that I always tell them, just keep them in your refrigerator. 6 months from now, if you want, just touch it up for a couple of nights and you will, touch up your bleaching. And normally they do it once a year. They don't even have to do it every 6 months because it's so effective. And again, we just had a publication. We just have one that's coming out soon in the Journal of Cosmetic Dentistry, a research that we did in Mexico using different concentrations and using patients that have kind of like same etiology. They all had single dark teeth. And we treated all these patients using 4 different concentrations. And we were not able to find any difference statistically and clinically visual amongst all these patients color-wise at the end of treatment, using 10% all the way up to 35% carbon peroxide. So, and we know that. We know that it's not about the concentration, it is about the time. And the greater the concentration, any concentration above 10% is going to create gingival irritation. So you're going to have some blockout resin placed on the cast. You're going to have some spacer, and you're going to have to trim your bleaching trays. You have to scallop them. When you're using 10%, you don't need to do any of that. Just cut your tray straight, give it to the patient. It's not going to harm the tissue at all.
I'm getting a little carried away because most podcast listeners are young. A quarter of them are still in school, and the rest are all under 30. I'm probably the oldest guy that's ever been on a dental podcast. But if you look at the insurance claims, I mean, there's 100 million claims a year. Now, I've lectured at dental insurance conventions in Florida. I've seen their data, and you put out the 32 teeth, and it looks like a flat line with 4 big spikes on the 6-year molars. That's a tooth most likely to get a filling, a crown, a root canal extracted. It's all that. So I want to bring this down to the 6-year molar. And she's got to go in there and do an MOD composite. And she's hearing some people bulk filling the whole thing in one increment and curing it. So just bring it down a level to an MOD composite on a 6-year molar. Brand name, how would you do it?
Well, there's a couple of things that I think that should be considered. I just wrote a paper, and it's going to be published soon, on rubber dam isolation. And you're going to ask me, well, Mario, why did you write a paper on rubber dam isolation? I mean, rubber dam isolation is 152 years old. Is there anything new that I need to learn? Well, I think it is. There is something new that you need to learn. There was a recent study published in the United States. It was in 2017. And what the study did was that they interviewed 3,000 dentists all over the United States and asked them, general dentists, and asked them, do you use a rubber dam? How many times? How often? 63% of these dentists said, I never use a rubber dam for restorative dentistry. Never. Out of the 63%, 32% said, I don't use a rubber dam, not even to do a root canal. Now,
say those numbers again. 63% never use a rubber dam?
Never use a rubber dam for any restorative procedure. Any restorative procedure. And 32% of those never use a rubber dam for root canals, which for me is scary. Because when we do a root canal, and I don't do any root canal, so I'm not going to talk about endo, but I am going to talk about one thing that I'm 100% sure of. The number one reason why you treat a tooth by means of a root canal is because the pulp has become necrotic or there's some type of bacterial contamination. So your number one goal is to remove that and to keep that area clean, right? So if you're working on a first molar, which is the tooth that gets everything, just like you said it, on a mandibular first molar, what are the chances of you getting saliva contamination? Extremely high without a rubber dam. So I think that there's still a discussion to be made with the rubber dam. And I know why you're asking the question of the class 2. Now let's think about this together. You have a class 2. Where does a class 2 normally fail? On the gingival margin. The gingival margin, let's say that we're not talking about a deep class 2. Let's talk about just a regular class 2. Gingival margin, 2 millimeters above the papilla. So you know that we have enamel there. What is the best tissue that you can bond to? Enamel. Is there any way that you, without a rubber dam, using, let's say, an isovac, which a lot of people like using today, using an isovac, yes, you're going to protect the patient, you're going to keep the tongue away, you're going to protect the back of the mouth, you're going to have light, you're going to have a dry field. But what's up with the curricular fluid right underneath your gingival margin? You're just a millimeter away. How do you control that without a rubber dam? The isovac can't control it for you. So if you look at every single study that talks about contamination of enamel and dentin during operative procedure and the damage or the how negative they impact our restorations, you will find that the negative impact of contamination of the operative field is extremely high. So my question to many of these young dentists or even older dentists, because I promise you that out of those 3,000, many were older, like me and you. So if you ask these students or these young patients, these young dentists, if this affects your operative field, how in the world are you thinking of what kind of restorative material I'm going to use to make this better? I don't care what you use. You can use the best bulk fill. You can use the best layering technique, the best composite, the best instruments, the best bonding agent. But what do you have as a substrate? You have a contaminated field. You have contaminated with glycoproteins, with saliva, and sometimes even with blood. If you have a deep class 2, how do you control that and how do you want that to be successful? Howard, I don't care if you use amalgam. If you have a contaminated field, your amalgam will fail as well. So for me, the number one thing is having an isolated field. With composite is extremely important. Then we can talk about materials. Now we can talk about bulk fills or layering. But first, have control of the field. Now, if you tell me, well, would it be the same to do a class 2 or a class 4 on an anterior tooth? Well, if it's a maxillary anterior tooth and you want to use some cotton roll isolation, you have more control in that area than you would have on a molar. So this is why rubber dam isolation is so crucial. And you know why that 30 or 63% of dentists said, I never use a rubber dam? Because what is the number one thing that a young dentist does when he goes into practice? He stops using the rubber dam, which he was good at when he was in dental school. So they stop, 3-4 years go by. It's like doing anything like that you stop doing. If you don't do this every single day, you will get bad at it. But if you use a rubber dam every single day, it'll take you literally not more than 30 seconds to isolate a tooth and be ready to do your restoration. And in a way that is predictable. And this is just a fact. I mean, we can't change this. We cannot lie to ourselves saying, oh, but there's other ways of doing this with blood and saliva in that gingival margin. There's just no other way. And if there's one, please, I want somebody to enlighten me and teach me how to do it.
If somebody swallows, if a root canal fails, I'm just talking about a root canal fails and the dental board gets your x-rays or whatever, and they cannot see an x-ray that confirms a rubber dam clamp on, you lost.
Well, then 32% of these 3,000 people are taking that risk, which is insane.
It's game over if you cannot prove that you had a rubber dam on during an endodontic procedure. So we know we need the rubber dam. So
number one.
Are you going to bulk fill? You going to increment fill?
I think that bulk fills, they have a huge, a huge stake in what we do every day. I think that they are something that came out to dentistry that is very, very good. There's a lot out there in the market, and we have to understand that there's different types of them. You know, you have the ones that are light cured, that they're going to be more of a translucent type of shade because you need the light to go through, and then you got the dual cured type of bulk fills that they're more opaque because they are either, you can cure them with a light, and if the light doesn't reach the deeper areas, they will dual cure, they will self-cure in those areas. So you got these two different types of bulk fills. Now, one thing that you got to keep in mind is if you are using or you decide to use a bulk fill that is a bulk fill that you have to light cure, you got to make sure that your preparations have a depth no greater than 4 millimeters. Now, you will find a lot of manufacturers that will tell you 5 millimeters. But what happens is that I'm going to ask you a quick question. So I'm going to interview you for 1 second. How many times do you, as a dentist, use a probe to measure how deep your preparations are?
Never.
So if you see, and that's the honest truth, I don't do it either. So we never know how deep they are. So my advice is, if you, for whatever reason, think that this is more than four, because 4, we know that the light is going to go through, but you got to make sure that you give 20 seconds of light. You got to give them enough joules, enough energy for that composite to polymerize. But if you, for whatever reason, and I have a lot of cases like that where they're super, super big, so I know that there's more than 4 millimeters, I still use a bulk fill. But I use my bulk fill in increments. Instead of using 2 millimeter increments, I use 3 to 4 millimeter increments. So I know that if I have 6 millimeters, I'm going to use 2 3 millimeter increments to bulk fill that tooth. And I cure both increments separately. So I make sure that I'm still using the benefit of the bulk fill, which is faster, quicker, and and we know that we're going to light cure through it. But the other reason why I think that bulk fills are so important in our practice is because how many times do you think one of these large class 2s is going to end up with a crown or an onlay? Very frequently, maybe in a year from now or 6 months from now. So I try to keep my inventory small. When I say inventory, I mean amount of products. I don't want to have a composite for core buildups and another composite for bulk fills and another composite for layering. If I can keep it simple and let's say that I'm going to choose to do all bulk fills on posterior teeth, then that same bulk fill is what I'm using today to seal my my pulp chambers on root canal treated teeth. And that same bulk fill is the one that I'm using for my core buildups. So I will prep the tooth if I need to, using that as my core buildup material. And I use it as my final restoration. And then I know that if I have it in a year from now, I got to, for whatever reason, one cusp fractured and I need to now do a crown on that tooth, I can use that material as my core buildup material underneath my preparation. So I don't have to remove it if it's still in good conditions. So I think that using the bulk fills simplifies a lot of what we do. But can we get away completely out of the layering technique? No, because you're not going to use bulk fills on anterior teeth. So you're still going to have some micro hybrid or nano hybrid type of composite in your practice for those other cases, or for the very minimally invasive type of, slot preps, very small class 2s or class 1s, where you're not, because the bulk fills, they come in these little compules where you have to literally throw them away once you're done with them. So you want to make sure that you have large preparations. And the other thing is that the size of the tip of that bulk fill is kind of wide. So but for very small preparations, it's probably going to be too wide, and it's going to be hard for you to control the way that the material is dispensed on your preparation.
Okay, they're going to want to know your brand, though. When you talked about bonding agents, you said Optibond Universal Cur or One Coat 7 Coltine. For bonding agents at Optibond, Fluoride Cur, 4th generation assets. What bulk fill do you like?
I use Sonic Fill 3 from Cur, and I use Fill Up from Coltine. And why do I have both?
Sonic Fill 3 from Cur?
Yes.
From Cur, and what was the other one?
The other one is Fill Up from Coltine.
Fill Up from Coltine, okay.
Now, the reason why I have these two is because Sonic Fill is light cured, Fill Up is dual cured.
All right.
So I use Fill Up a lot. Let's say I'm going to give you a good example. I use it a lot for when I have implant crowns that are screw retained, and now I have to backfill that screw hole. I use Fill Up because it's very opaque, so it doesn't let any metal show. If it's a PFM, it's tooth colored, so it looks nice on a zirconia type of restoration, and it's dual cure. So I don't care how deep my chimney is. If it's 3-4 millimeters, it's still going to polymerize completely without the presence of full light all the way down.
For bulk fill, Sonic Fill 3 composite for light cured, and then for Fill Up from Coltine for dual cured.
Yes, sir.
Okay, and you already told us you're a bonding agent. I have heard people on this show come on and say that dental supply reps, that they can go out and say they have 25 dentists on their account, and they go and they test the light of all 25 dentists. Half the lights aren't even acceptable. And they're saying that dentists always want to know what bonding agent to use and what composite to use. And they're saying, dude, your light doesn't even work. What light do you use? And how does this dentist she's driving to her office right now, and she's going to get there, and she's got to do an MOD composite on 3. How does she even know if her light's even working?
Well, for the light even working, you have to use a radiometer, and you have to make sure that the output of the light is at the minimum, I would say 450 megawatts per square centimeter at the minimum. Ideally we have 600, 1200, and it's not about the intensity. It's more about the time, the time that you like here. And this is another good advice that I can give the younger dentists is that you normally they use as the reference their the person that visits them, the rep that works for the dental company. Well, guess what? The rep is not a dentist. The rep is somebody there. He's there to sell, and he's there to help you out. He will answer many questions, but he doesn't know the facts. So, a lot of them go out and say, oh, if you use my curing light, you only need to cure for 5 seconds. Well, here at the school, Dr. Fred Rugerberg, he's done a whole bunch of research on curing lights. And what he has found is that the lights that say that you can only cure 5 seconds, the conversion rate of the composite with that light intensity at that time is a lot lower. It's always less than 60%. I would say closer to the 35 to 40% range compared to using the same light for 20 seconds, 4 times the intensity, where you're now going to be in the numbers that are 65 to 70% conversion from the monomer to the polymer. And that's what you want, because you're never going to get 100% conversion because you have oxygen, and oxygen inhibits polymerization. So the higher that number, the better off you're going to be. And that's a really good point. You see, dentists worry about, what adhesive do you use? What composite do you use? But nobody's capable of measuring their own lights in their practice. And guess what? The reps that visit your office, they normally have a radiometer. So if you have a rep come to your office once a month, just ask him to measure your lights and make sure that you have the highest output possible for the brand that you're using. Here at the school, we use the lights made by Ultradent in the entire school. So the Velo light is the one that we use here at the school. And, that's the one that has the most research. It's a great light. The good thing about the ones that we have is that we have the cabled ones. So they're connected, they're powered through a cable that goes onto the wall. So it gives you constant output at, with the same intensity. When you have the cordless ones, you got to make sure that the charge on these cordless ones is high enough to get the output that you're looking for. But regardless of that, you want to make sure that you have that time is an important factor, that you consider time. And, I never cure anything for 5 seconds. Everything is for 20 seconds minimum. And, if your light has a lower output, you're going to have to increase that time from 20 to 25, because, again, you're having now less energy coming out through that tip of the light. So you have to increase the time in order to get the right amount of energy output.
Okay, it's really scary when you're young. You just got out of school. You just got your first job. You did an MOD composite, and you're driving to work, and the patient came back and is on your schedule because the tooth is sensitive. And
Right.
she's like, oh my God, so talk her through it. She did an MOD composite a week ago, and the patient's coming in, it's sensitive.
And normally me and this is quicker than a week ago. It'll happen the next day. Patient go home and say, hey, you know what? I had this amalgam that you said it was bad. It was there for 30 years, never bothered me. You remove the amalgam, you put this white stuff, now it hurts. And let's think about that a little bit. Let's think about pain. Many things can cause this. One of the most important factors when we're talking about class 2s is what I call the remaining dentin thickness, or RDT. So how much dentin is still solid, nice and healthy dentin is still on top of that pulp. And many studies have shown that the minimal amount of dentin required so that the dentin can protect the pulp 100% is minimal 1 millimeter. So you need to have at least 1 millimeter of dentin on top of that pulp chamber so that you can acid etch, prime and bond and have complete protection of that pulp, meaning that you're not going to get any resin globules into the pulp in contact with that live tissue that will create a cytotoxic effect that will be felt by the patient as postoperative sensitivity. If you are in doubt, and this is my best advice for young dentists, if you are in doubt clinically on how deep you are and how close you are to that pulp chamber, the best and easiest thing you can do, use a liner. Use a resin-modified glass ionomer like Vitribond, right on that dentin, right on top of that pulp, and seal that dentin. And then you can go ahead, acid etch, prime, and bond, and have no issues. Because now that you've sealed the dentin, there is no chances for the monomers in your adhesive to infiltrate and get to the pulp. Because don't forget, if you have less than 1 millimeter of remaining dentin thickness on top of that pulp, you will get resin globules into that pulp in contact with that live tissue, and that will create a problem. That will be one of the things that manifestations is hypersensitivity the following day or 2 days later. So many young dentists think that is normal. It is not normal. You can do a lot of operative dentistry without having that secondary effect. And the way of doing that is managing the remaining dentin the right way. And that is either through the liner or through choosing a specific system for your adhesive dentistry. Let me give you another example. Let's say that you don't want to use a liner and you don't know how deep you are. You are very, very deep, and you think that you are probably up to a millimeter or slightly less than a millimeter away from the pulp. Well, you can now use a universal adhesive, or you can use a self-etching adhesive that I like, because there's a lot of them that come in 2 bottles. And I like when they come in 2 bottles, because now you have control over the primer and the bonding of these self-etching adhesives. Now, I don't use self-etching adhesives on my enamel. I selectively etch my enamel, always with phosphoric acid. But if I am in fear that I'm too deep and I may cause some irritation of the pulp, I rather use a self-etching adhesive for that dentin instead of a total etch technique where I'm going to remove more of the smear layer and I'm going to etch more into that tube. I'm going to be my etching depth is going to be greater using phosphoric acid than using a weak acid like the ones that come into the self-etching adhesives. So those are 2 ways that you can combat this, either with a liner or not etching the dentin and using a self-etching adhesive.
Okay, but a lot of times when they're young and out of school, they don't know, is this the bite? How does she know if I should adjust the bite or if it was everything you just said? And if she does everything you just said, should she still adjust the bite?
Well, that's a really good question, because if let's say that it is a occlusal trauma, you're hitting the tooth more than you need to, and now the tooth becomes sensitive. Well, the easy thing to do there, the patient is not going to know why they have sensitivity. They're just going to tell you, I have sensitivity. So the number one thing that you're going to do is first check the occlusion, centric and lateral excursives, and look at the tooth. If the causing factor of that hypersensitivity is hyperocclusion, and it's not been going on for 5 weeks, it's just been going on for a couple of days, most likely when you eliminate the interferences on that tooth, the patient is going to feel improvement right that moment, because you're not going to place any anesthetic. If there is no improvement, or you did not find any interferences, lateral excursives or centric interferences, then you know that most likely is something to do with the adhesive layer on that tooth, with that hybrid layer that is not ideal, and that's why you're having the postoperative sensitivity. And the only way of getting rid of that is removing the restoration. So that's an easy way to assess what is the causing factor for this hypersensitivity.
You do so many different things. You also did a YouTube video on the Hohen technique. What made you do that and talk about the, am I pronouncing it right, the Hohen technique?
Yeah, Hohen technique. Well, that Hohen technique, what you're seeing on the video, was actually done by the endodontist that I work with here at the school, Dr. Bergeron. He's the chair of he's the director of the endo program here at the school. And that was one case that we had together. This patient had a root canal and an apicoectomy done on that tooth initially. And, a year later, he had a recurrent infection. And it was a large infection. So the Hohen technique is kind of like a minimally invasive type of treatment, meaning that it's just like treating a fistula. It's a very small opening where they just they drain everything out of that area. They clean that area very well, but they don't have to go ahead and redo the apicoectomy. So everything is done through a very small little access, and it's more of a draining process. And it's a way that they then follow up. And then, if if there's no recurrency of the infection, then they know that they're good, and they follow up for the patient for a full year. So that video was done by Dr. Bergeron during that specific procedure of a patient of mine. And the reason he videotaped it and he shared it with me, because what I did for that patient was a restorative side. And it was interesting for me that even though the tooth had because what do you hear often? You hear that, oh, if you have 2 root canals done on that tooth, most likely you're going to remove the tooth and place an implant. Well, for this particular patient, he had a root canal, he had 2 root canals, 1 apicoectomy, and then he had the hone technique done by Dr. Bergeron. So that tooth was treated because of issues in that canal 4 times. And even though it was treated 4 times, right now I think that we're like in the 3rd year of follow-up of that patient. So we were able to get rid of the issue with the technique that Dr. Bergeron used, but we didn't have to remove the tooth, and the tooth is now restored and has been in good shape for the last 3 years. So that's kind of like what we did that video. We did the video kind of to show that, that endo is a really good option when it's well done and when it's done by a trained, highly skilled and trained person. And that's, I don't have anything against general dentists doing endodontics. I think that if you like it and you're good at it, by all means, go ahead. And I think that it's something that you should learn how to do and do it well. On my particular case, Howard, I'm really bad at it, and I know it, and I'm very frontal about it, and I tell everybody I'm really bad at this. You would never want me to do any root canal for you, so I refer everything that comes to my practice, and I've been doing that for the last 23 years. I don't do any endo at all. And obviously, I feel highly and I talk highly of the specialists because they've helped me so much with so many difficult cases that have been successful, that worked out well in my hands because I've only dealt with the restorative part.
And what did you say his name was? The endodontist, Dr. who?
Dr. Bergeron.
How do you spell that? B-U-R?
No, B-E-R. G-E-R-O-N. Bergeron.
So you're not an endo man, huh? What does the word micro-abrasion mean to you? When back in the day, there was that Danville unit that sprayed and that cleaned off. I just loved it. But my dental assistant for 30 years hated it because it was so messy. But your crown came off or whatever, and I take this little micro-abrasion from Danville Engineering. And then they made some bigger ones. I had like a $6,000 micro-abrasion unit. I forgot the name of it. Back in the day, but I loved it. But nobody loved the mess. It didn't take off. Looking back, it was kind of a fad. But what does micro-abrasion mean to you? And do you use any micro-abrasion?
I use micro-abrasion. I use a micro-etcher too from Danville Engineering. I use it to micro-etch my the metal crowns, gold crowns. I use that to micro-etch the integral surfaces of my zirconia crown, which is, I think, something that we should talk about a little bit, because obviously everybody's using that today, and there's a lot less of metal, real metal, black metal being used in dentistry today, PFM type of or gold crowns. But I use the micro-etcher. I don't use it a lot on patients' teeth. The micro-abrasion the technique that I use is actually I use a product from Ultradent called Opalustre. And Opalustre is a product. It has hydrochloric acid, 6.6%, combined with pumice and some abrasive particles, abrasive carbide particles. And there's 2 ways that you can do abrasion of enamel. It's either macro abrasion, and you must remember, and I used to do this many years ago, where we just used a little burr, fine diamond burr, and white spots, and you just kind of gently went on top of them until you slightly remove them, and that's called macro abrasion. So you're using a diamond burr to actually roughen or remove some stains on patients' teeth. Micro abrasion is at the micron level. So you're removing, I would say, 70 to 100 microns of enamel when you're applying this. And I just have a nice case that was published just recently in the Journal of Cosmetic Dentistry. And when we submitted this paper for publication, this clinical case for publication, one of the comments of one of the reviewers was, well, how much enamel are you removing? How can you consider this minimally invasive if you're still removing enamel? And what we did is that we actually took a photo of the patient, a very nice photo, where we were able to capture, it was a side photo, where we were able to capture all the micro texture that was in her enamel after the microabrasion. And they actually added that photo to the article. And the beauty of the photo is that you're looking at all this beautiful intrinsic characteristics of the enamel, microanatomy of the enamel that was never removed by the microabrasion. Because again, we're at the micron level. You're removing 70 to 120 microns of enamel where those stains are, where those white, brown stains are located. But underneath that, you got some nice translucent enamel left behind that now, once you remove the surface layer, you're able to eliminate whatever the patient disliked about her smile. Sometimes, fluorosis stains, either white or brown stains, depending on the level of fluorosis. But that's what microabrasion is all about. Microabrasion is about using this product that you use on the surface of the tooth, and you use it with special cups. And these special cups are special because they have very stiff bristles within them, so that you have a little bit of mechanical removal of enamel at the same time that you're having microabrasion. So it's a combination of mechanical removal with those stiff bristles and chemical removal with the microabrasion of the product, with the acidity of the product and the abrasiveness of the product on top of that enamel. So this combination is what removes that surface enamel where the stains are located. And that's what I normally use for my adult patients that have white spots, either for fluorosis or just hypermineralization of enamel that that have been there for years, and that they're not suitable, or they will not be removed correctly or completely by enamel resin infiltration. So you got to kind of choose between resin infiltration and microabrasion to see which one would work best for that specific white spot that you're trying to eliminate.
I love your website, romerodentalseminars.com, romerodentalseminars.com. September 28th, you have Mastering the Aesthetic Prototype for Partial and Full Mouth Oral Rehabilitation. May 17th. We already passed that. What is this? Today's July 1st, 2019. So your next one is September 28th, right?
Next one is September 28th. Yeah, we normally, when I'm out there, probably, I would say, 5-6 big dental meetings a year where I'm lecturing a lot of hands-on courses. I really like doing the smaller courses, 30 participants, like the one that we're going to do in Atlanta, Georgia on the 28th, because it allows me more time to kind of sit down, one-to-one and kind of, work with them and kind of guide them through the process. Because again, when we really want them to, like the title of the course says, we want them to master the prototype. And when you say master, it really depends on regardless of the case that you normally have in your practices. It can be partial or full mouth cases. This same concept is going to help you understand and guide yourself through an easier process from start to finish when you deliver your restorations.
Well, I love that. I'm always harping on my homies that the average American buys 17 cars in their lifetime. For the average new car is $33,500, and they on average they'll buy 17 cars between that and age 76. And then I look at every dentist that retires, and 90% of them never sold one case for the average price of a new car. And they spent their whole life saying, well, it was the insurance and Delta and PPOs. And it's like, no, dude, it's you didn't, when they buy a new car, they're exhilarated. They post a picture of it on Facebook. They come by your house and, you walk out there and act like, you're enjoying this new child that was born. I grew up in Kansas. They upgrade a new F-150 for $50,000 or an F-250 or $100,000 F-350. Every 5-6 years they buy that. And then that dentist in that small town has never once suggested, hey, how would you like to have all your teeth done, a new smile makeover? And you know what? You paid $40,000 for that F-150 truck. This won't even cost you $20,000. And, the only, living in fear is not an option. And when you're practicing dentistry in the richest country in the world, where they buy a new car every 5 years, they buy a brand new car. I just love the fact that you're sitting there doing courses, mastering the aesthetic prototype for partial and full mouth oral rehab. if you haven't done a full mouth oral rehab, hopefully you just graduated from dental school in the last year or two and you're not quite ready. And a course like this will get you totally ready. Or you just don't love dentistry. You just don't think people want to drive a new car with their new smile. I mean, I've done full mouth rehabs on women when they looked in the mirror, they burst out crying. I mean, I had this one in particular where she knew she was in for a denture. But I convinced her, no, you don't want to do that. We root canaled every remaining tooth, placed a couple implants in each corner, made her a couple, all fixed. I mean, it was the greatest moment, of the year for her. She just loved it. And I hope you are listening to this. I hope you go to RomeroDentalSeminars.com. Was there anything that I should have asked you that I wasn't smart enough to ask you?
No, I think that you conduct your interviews in a very special way, and I really enjoy the way that you do it. I think that you've asked really good questions that are going to be helpful for the young dentists and sometimes even for the older dentists as well. I mean, it really depends on what you're doing in your practice. I just want to tell everybody that, I've been teaching for 23 years. I've been teaching for 20 years. I've been a dentist for 24 years, but I've been teaching for 20 years out of those 24 years. And, part-time initially, now I do it as a full-time job. And one thing that I can tell you is that I love sharing the knowledge. If it's through webinars, I write a lot. You go to my webpage, there's a site where you see publications. There's a lot of my articles are there. We have over 100 hours of actual teaching videos in Spanish and in English. So, because I used to teach in Spanish only up to 7 years ago that I moved to the United States. I've been here only 7 years. So you'll find out, over 100 hours of videos, me lecturing for over an hour in different topics, occlusion, aesthetic dentistry, restorative dentistry, and all that is free. I mean, I always joke about in my lectures that my website is the only website in the United States that you can get stuff for free because everybody's charging for their stuff. I ain't charging for my stuff. I just give it away because I think that one of the most beautiful things of what I do is that I share my experience. And I've seen a lot because when you're in an academic environment, you see everything. And, just getting these younger dentists feeling proud for what they're doing and just getting them motivated to continue, their learning. Because this is a lifetime learning commitment when you become a dentist. Every single year you have new products. Every single year you got new techniques and you got to stay up to date to that. What we do at Romero Dental Seminars is we try to simplify that. We do have our hands-on courses that we do, and obviously those have a cost because obviously there's a lot of cost associated with us getting it done. But we do a lot of stuff that's out there in our YouTube channel that is free. Nobody has to pay for it. You can just go ahead, click on it, and you're ready to go. We have a very active Facebook page as well called Romero Dental Seminars, and there's a lot of cases that I upload there, just showing little tricks and tips, free. No payment, no subscription, no anything. So it's just let people know that we do this because it's really what I make. This is really what I live for, teaching and sharing knowledge.
And you know why Facebook is so awesome? Because Mark Zuckerberg's dad, Ed Zuckerberg, is a dentist. And he comes on the show once a year. He even posted on Facebook on Dental Town the other day. He always updates what you should know best about marketing your practice on Facebook or running your Facebook pages. It's just amazing. But thank you for all that you do for dentistry. Thank you for sharing so much. And congratulations again. I mean, you got the Excellence in Dental Education Award from the Pierre Fauchard Academy. I mean, you've been published 40 times and you've taken the time to come on my show. It was just an honor to podcast interview to you today. Thank you so much for coming on the show.
No, thank you very much for the invitation. I really enjoyed myself.
And I really enjoy your YouTube channel. I've watched every single video on your YouTube channel and left some comments after some. So thanks again for coming on the show.
Thank you. Thank you very much for your time.